Welcome, everyone. We can see you, Mike, but you are upside down. I'll give everyone just another minute or so we can get enough folks. Again, welcome. If you're here for the Operations Committee meeting, you're in the right spot.
Okay.
Well, it looks like we have 5 folks here. Isabel, is that right? Oh, 84. We have 5 committee members yet?
I think we've got 4.
We got 4. Okay, wait another minute, and then we'll try and do roll call, but then nothing's getting voted on today anyway, so we can always get going, but we'll give folks one more minute. I know Judy Richardson is not able to be here today, so she gives her regrets very much to miss the last Operations Committee meeting. Oh, right on. There's Doug. Super. Well, no, we have a quorum. Let's get started. So thank you, everyone. This is the March 26th Operations Committee meeting of the Universal Health Plan Governance Board. This is the final Operations Committee meeting, but the work will live on. As I'm Dr. Mimi McDonald, the Executive Director of the Universal Health Plan Governance Board. Judy Richardson, who is the chair, is not able to be here today. So I'm afraid you will be getting a lot of me. My apologies for that. So we're just going to get started. And Isabel, are we ready to do a roll call?
Yes, we can. Judy Richardson, as you said, is absent. Bruce Goldberg is on leave. Mike Leahy.
Present.
Thank you. Laura Byerly. Don't see Laura. Doug Flo. Doug, if you're able to unmute and let us know you're here. I see your name in our list.
Doug is here. Thank you.
Thank you. Sarah Fouché. Don't see Sarah yet. Michael Horay. Don't see Michael yet. Lori Hoagland.
Here.
Thank you. Doris Karagu is absent today. Anne Lovejoy.
Here.
Thank you. Paula Weldon.
Here.
Thank you. And that's everyone for today.
Thank you. Well, as I mentioned, today is the last meeting of the Operations Committee, which is not a new announcement. But let's go on. We'll do our agenda review. I'll share with the group some committee and board updates. We're going to have kind of a discussion and a sort of a brief review about administrative savings that are available in a universal health plan and how we can accurately quantify things. We're not coming up with a number today, but really like a strategy to think about it, because there are multiple factors going into it. And then I'm just going to briefly go over all of the work that the operations committee has done, which is, I think you guys will be amazed, a tremendous amount of work. Then we'll have some member reflections. I don't know that we have any public comment signed up for today, so I think today is probably going to be a relatively short meeting. So we're just going to get going. First off, I'll talk about our board meeting, which was, goodness, that was on the 19th of March. It was just a week ago. It seems longer ago. So at the board meeting, we had a great talk on sort of an economic overview. We had the Milliman gave an overview of the operations report that they have worked on, and it's so we're excited to get the final of that. Board talked about administrative efficiencies, sort of the federal programs that this group has discussed before and how there can be alignment with the federal programs, then also discuss cost containment strategy. Finance and Revenue has had their final meeting. That was on March 17th. They are, of course, they have worked on the revenue strategy and a reserves revenue strategy. They are just, at this point, the committee's providing feedback to our consultant group, Echo Northwest, on Echo Northwest's report. And so that final report will be coming in front of the board in April. Plan design and expenditure wrapped up this March 5th. Community Engagement and Communications Committee, however, has gone back to meeting on a regular basis. Their monthly meeting have resumed, excuse me. And one of the things that they have changed, I think I may have mentioned this at the last Operations Committee, is that the CECC meeting time has changed. So it starts at 4 in the afternoon and goes until 6:30. Sort of deliberately trying to do it outside of those 9 to 5 hours, so more people have an opportunity to participate. And between the hours and 5 and 6, they're really dedicating that entire hour for people to be able to provide public comment. It won't be sort of a back and forth comment. It will still be kind of what we're familiar with, but people will have the opportunity, as long as they sign up in advance by 24 hours, to comment. I'll have a little bit more time, 5 minutes instead of the usual 2 or 3 minutes. So that's been great. The other work that's been happening from CECC is the month of March, we've had, we're doing targeted engagement meetings with all different types of groups. And I have to say they've been tremendous. We've met with people from CCOs, insurance companies, providers, small businesses. I'm missing some, there's more to come. And really, it's been incredible. Those people have been just given absolute candid feedback, really frank, a lot of it positive, and some of it, I wouldn't say negative at all, but just people have a very, sort of different either opinions or ways that they think that the proposal should go. So that is great. The work of that, Diana Bianco from Artemis Consulting is creating a report for all of that. All of the comments will be anonymized, but that report is going to be available, and hope to get in front of the board sometime in April with just really valuable feedback. So that's exciting. And then last but certainly not least, the transition committee, we had a kickoff meeting, which is great, on March 19th. And already are working on have some agenda items planned for starting the work at this next meeting. And then at this next meeting too, we're going to work out all of the sort of the future meetings. That committee is actually meeting twice a month instead of once a month. Currently, the times are shorter, so it's just for an hour and a half, but really trying to create a plan that gets us from where we are today and to where the, sort of the proposals end, finishing point several years into the future, and sort of a strategy to get there. So I'll stop and pause for a second, see if there's any questions about that. Lori.
Yeah, I was curious with the report that Diana Bianco is going to complete. Will that be presented to the Community Engagement Committee first, or does it go directly to the governance board?
That is a great thought. I'm trying to think timing wise. I think it is going to get in front of the board before CECC. Now I'm thinking about that. I think that's what's going to happen. We are trying to get that information. We want it to get in front of the board sort of sooner rather than later. And in fact, there may even be kind of a special board meeting just with that topic, because we want the board to have the information as they're making decisions about the proposal. But it will also be at the CECC meeting. I'm like looking at the calendar in April. And I'm not sure, but we'll find out. I do think it's the board first, but it depends on the timing of when it's completed.
If you have a special session with the governance board on that, how will you will that be available for the public to participate in?
Yeah, absolutely. We'll just, so we have that giant listserv, and we'll send that out as an invite. And then I'm trying to think, it would be, sorry, my brain is not functioning right now. I'm trying to think about when it would be. It would be after the board's meeting, the mid-April meeting, if it does happen. So we would also announce it at that board meeting too, and we talk about it at the transition committee. So kind of the usual ways that we let people know about it. Great questions. Thank you, Lori. All right. So I'm going to go ahead and start talking about administrative savings within a universal health plan. And this is a topic, certainly this group has looked at plan design and expenditure. I'm drawing really heavily upon a report, a white paper that our colleagues at Health Management Associates, HMA, created a memorandum on administrative costs, but then also with some additional research and some further information. And really what I hope to get out of this and to really get feedback from this group is sort of one is the way that we are thinking about using all the information for that is out there that can sort of quantify administrative savings. How are we truly going to utilize all of that information in a meaningful way to help the board make decisions? So hopefully you guys will come along on this journey. It's not too long, but here we go. Right. So one of the first things to think about is, well, what exactly do we mean by administrative costs? There's a professor, Dr. David Cutler, who has done a tremendous amount of work on this topic and in this area, and has multiple papers out about it, and describes administrative costs as the non-clinical costs of running a medical system, which is kind of a nice way to do it, but I think that sums it up. The reason that I have the next couple of bullets, frequently when papers are written about this, things are described as being billing and insurance related expenses, so BIR, or non-billing and insurance related, so non-BIR. So billing and insurance, you can imagine, claims management, clinical documentation and coding, and prior authorizations are usually lumped in that group. And then non-billing and insurance related, so like all general business overhead, which is a tremendous amount, goes into that group, but also they include quality assurance, taxes and profits, credentialing costs, and customer service. But really kind of thinking about that, and of course we think about administrative costs on the payer side of just doing the business of administering the health plan, and then of course on the provider side, which it's even frequently takes up even a more significant amount of time. So as we think about this, I thought what we're, kind of what we're trying to get to is I put accurately predict the amount of healthcare dollars that will be saved by transitioning to a unified payment system. And as we talked about, it's not exactly single payer, there's still going to be some of those federal dollars and things like that. But really we're trying to get that. And of course, it's not going to be a specific dollar amount, but how can we, again, use all this information? Because there are a lot of challenges when we bring this information together. There isn't a US state model to base estimates on, so we haven't seen it done before. It is very different what it would look like for a state operating a unified payment system versus a country which could truly have that. Next, estimates of health plan savings are pretty uniform, but provider savings can vary widely, really depending upon the practice and the system that they're utilizing. So that does add a challenge. This one I added in, just the introduction of AI into healthcare writ large is rapidly changing how providers and health plans operate. And so that's another factor in the equation. And then lastly, like many things in academic studies and what are called gray papers, sort of like industry journals, they don't always have a consistent way of measuring the savings. So lots of times it's definitely not apples to apples. It's like apples to oranges and tangerines and grapefruits and bananas. But we're trying to, again, get to this task. And one of the ways to break it down is to know how much could be saved. One, you need to know current total healthcare costs. Then you need to know how much of those costs are administrative. Then you need to know what type of administrative cost is considered wasteful, because not all admin cost is wasteful. I mean, you need some of that. And then what percentage of those wasteful costs would be eliminated with a unified payment system? So, and you guys just raise a hand or stop me at any time if you have any thoughts or questions as we go along the way. Okay, so first off, we're going to look at total Oregon healthcare costs. And if you, and you will notice there's different numbers of different years because data is always challenging to get. So KFF, which is a really very reliable source, but their last data was from 2020, or that's the most recent that they had posted, put Oregon at about 42.86 billion for an annual cost. Of course, the Optimus report that was created for the Joint Task Force, they used a baseline expenditure year of 2019, and at that time it was 37.57 billion. Their status quo projection, so not what they thought would happen under a universal health plan, but just if things were status quo, they projected $55.6 billion. I put the Oregon Healthcare Cost Trend Report information in here because it's out there and available, but it is incomplete. And so it is useful in the way that it measures a trend, and it can certainly, and I think that it's getting more and more robust as time goes on. But you will notice that that is substantially lower than other estimates. So in 2023, their estimate was only 38.7 billion, which you can tell is significantly lower than the 2020 cost. So again, that report is useful. It has a lot of great information in it, but not necessarily a complete picture. And then our Echo Northwest team, using starting from a baseline of the Optimus report and then using various sources, they trended to 2022, where in their 2022, they got to 43.2 of baseline. And because that was the year that they did a lot of their analysis on. This RRT that stands for Revenue Replacement Target, which is the amount of funding that the revenue plan is trying to solve for. And so that's why this is important. So off the 2022 dollars, that was 16.9 billion, and they projected that forward to 20.1 billion would need to be made up. So essentially that is the amount that is not coming from the federal government and would have to come from state and individuals. And then lastly, the Milliman report that you guys are familiar with, their projection in 2026 was 60.3 billion. So as you can see, even with all the best estimates, and this is going to be part of the theme of this, is that there's still a fairly wide range, give or take 5 billion. That's still a pretty big percentage of money when we're looking at this. So again, that's total healthcare costs. So there's a range there. And next, trying to look at percentages of total costs that are considered administrative costs. So a couple of, again, really often cited reports this one from the Senate committee report, and actually Dr. Cutler wrote part of this too. They give, and I think this is often used, administrative expenses ranging from 15 to 30% of that total medical spend. So again, a pretty wide range. But one thing that I think is very useful from this estimate, they believe a third of that is the administrative costs related to health plan and 2/3 of it related to providers. The McKinsey report in 2021, they kind of, instead of having a range, they just said, well, it's about 25% of total healthcare spending. But then they broke it down differently, like who has more administrative costs. So private payers, private insurance, 19%, hospitals, not surprisingly, really high at 26%. Physician groups, lower at 22%. Public payers, so you think of Medicare and Medicaid fee for service, they definitely have lower administrative costs. And then just other sites of care sort of rounding out again about 24%. So again, we got this range, 15 to 30, possibly closer to 25%, because that was back from 2018. Okay, and this is a little bit more of the same, but this is just where some of the studies came from. And you'll notice here that this is the name of the study that has this year of study data, total spending, then compared to the total NEH expenditure in trillions, administrative spending as a percentage of that national health expenditure. And what's over here is what's important is they talk about, is this that BIR only administrative, or is this the whole kitchen sink? So, oops, excuse me. Oh, goodness. So for this wool handler one, which also is often cited, has 25%, so a higher end, but that's everything. The ones that are BIR only, you'll notice, are a lower percentage. So that's where we get 13, 16.8, and 14.4. So really, though, for the purposes of what we're doing, we're looking at the whole package. All right, and sorry about this. This is a lot. Some of it is from the same studies. And again, you'll have the administrative spend here in this column. But then what we've included here, I mean, I didn't make this, but what is included in this table is administrative waste dollars. And then this percentage, it's the percentage of administrative costs that are felt to be wasteful. So a percentage of a percentage. And in this first study, which again includes everything, BIR or non-BIR, their estimation was that 71% of the administrative spend was wasteful. It's a pretty high estimate. Others are a little bit lower. For BIR only, it's ranging, say, 46 to 50%. BIR only, this study, 74%. And again, this is the percentage of wasteful spending of administrative costs. And then this BIR only one, about 50%. I go to a couple more. Let's see, this one, Himmelson and et al., comparing it to Canada. Again, we did not compare favorably with the percentage of admin spend that is wasteful. It's almost 74%. Cutler, the person that I talked about at the top, was less at 26 to 34%, and then finally 27.9. So down here at the bottom, sorry, because this is probably not that easy to see, but I just put in the range. So if it's just billing and insurance related, the percentage of the spend is anywhere from 13 to 16.6%. The waste, 46.5 to 74.3, again, estimates. And then when you include everything, of course, the percentage of the total spend is higher. And the range of what is considered waste is even broader. So again, we're looking at these, these are, vastly different numbers and percentages. So I wanted to briefly talk about in all of these studies, kind of the areas in which suggestions were made, that there could be administrative savings, things that could be done. So ways to reduce costs under payers and under providers. And I'm trying to think, we'll just kind of go through the payers first. Of course, simplified claims processing, no need for marketing, no brokers' commissions, and since it's going to be a public not-for-profit corporation, the elimination of that profit margin. So it's ways to reduce costs on the payer side. I don't know that the payers would look at it like that, eliminating profit. But also, we think about health plans. They often have multiple plans that they develop, and that spends a lot of time and effort creating those plans and a lot of actuary time. So there'd be a reduction in the number of plans, obviously. So that would be different. Uniform fee schedule. Hospital global budgeting is a little bit in the middle of an administrative cost and a cost saving effort, but certainly both for payers and providers, it would make the BIR much less. And then standardized contracting, which is something that I don't think we've talked a lot about, but also is something that has been really shown to make a significant difference in terms of cost. And then we've talked a lot about this in terms of provider side, billing complexity, not having point of service collection. They would no longer have uncollected, unpaid bills because they would be paid through the Universal Health Plan. We have talked about this as well, a single set of quality metrics instead of providers having to deal with multiple payers, one formulary. So it'd reduce the burden for credentialing that is out there, reduction in contracting costs, ease in patient registration, certainly so for front office staff, single set of PA requirements, and then I put enhanced clinician satisfaction and efficiency, because certainly provider turnover, clinician turnover is a big part of it, and would be a cost saving effort. So that was so much, but I wanted to pause and if there's something you're like, oh, but there's this big thing that I think is going to be important, and I want to make sure that we take a look at. Mike.
Yeah, well, first of all, excellent framework. I've been thinking about this, and maybe Anne could speak to this as well, about her perspective from a quality improvement perspective. But as we kind of migrate from this status quo to this kind of theory of which items might have, if we and as a board, we haven't really, since I've been on it, we haven't addressed whether are we going to do this kind of all at once, or is this going to be a staggered approach? Because I think many of these things we could have savings, but would not have all the savings if until we get to a certain part, and then if the Universal Health Plan has, let's call it a learning curve, begins to figure out how to do this better, and as the providers begin to figure out how to do this better, as well as if they have more staff than they need, what's the strategy for that? So maybe my simple question for you, Mimi, are you beginning to think about if we have multiple parts starting at different times, and how that might affect our analysis of administrative savings?
Oh, absolutely. That's why this is like, one of the top things. And I brought this to operations committee, and everyone who's on the transition committee, sorry, because you're going to see these slides again, but they'll be even better. But it's imperative, because I think it speaks directly into that, Mike, and it's a little chicken and eggy, like, well, you get all these savings, so let's do it all at once, but it's going to cost so much, so let's not do it all at once, so I think that absolutely thinking about this so transition committee can get it and their thoughts around these savings, and then get that in front of the board. So absolutely. Lori.
I was curious, I'm on the Prescription Drug Affordability Board and am totally amazed by the complexity of pharmacy in our state and across the country. But I wondered, how much detail is encompassed in these estimates? Because I think about, for instance, the real high-end medications that are currently targeted on television for these chronic diseases. And I'm sure there'll have to be some decisions in terms of what's covered, what isn't. Then, of course, there's the 340B program, and that's a federal program, and its overlap with state programs. And I'm just curious. I'm not a real numbers person, but I just wonder how much is thought about when they're making these numbers.
Yeah, like how much that, well, and I think that's a great question, and that's kind of part of what I'm talking about. So some of them, it's when, for example, when it's directly comparing the United States to Canada, like that's pretty clear about that it's not really theoretical, it's just, and now it doesn't mean that you necessarily that the US can save that, get that 73% administrative loss of savings back, but you can really see the actual difference. Some of the other ones though are not just, but are estimates of what might be and proposed efficiencies, that, as I mentioned at the top, I mean, we don't have this in a state system. So I would say it's kind of both. There's some things that are specific and some things that are less specific for sure. And again, as we're talking, even you would think like, well, don't we really know every year how much is spent on healthcare? And the answer is not really. So I think that's part of it too. It's like these are, very large numbers, and even a small percentage change goes a long way. So that was a long way of saying kind of. Some are precise and some are not.
Well,
again, yeah, Laura.
It feels to me like the two big questions that people have with changing the system in this direction is, how are you going to pay for it? And the second one is, how are we going to decide what's covered and what isn't covered? A lot of people are nervous about, not being able to have the same. And of course, I haven't done enough studying of countries where they no doubt are also using, new therapies, et cetera. But yeah, I mean, how do you answer the question about what's covered and what isn't covered? I know Oregon had that system of points for a very long time.
Yeah, I think some of that, well, is still sort of being worked out by the board for sure. I will say one thing in it kind of in favor of looking at these studies is that the vast majority of them all show that a unified payment system is less expensive, even when you're covering more people than our status quo system. So I think that's one thing that's really positive when you talk to people about how can you pay for this. That's one thing to kind of hold on to, is that it will be less expensive, and more, even with more people being covered, it will still be less expensive. So I think that's one sort of positive thing. But then I think that is, in terms of what's covered, what's not. I mean, those decisions, I mean, some of the decisions happen at the federal level if you're following CMS rules, and some, and Medicaid as well. And then there, in Oregon, we have the Health Evidence Review Commission, which is part of that. And I think that though, sort of the, someone at one of the focus groups talked about having an ethics commission as part of the work that goes on in ethics board. So I think those are really good questions that aren't completely answered yet, for sure. Anne.
Yeah, just generally speaking, when people ask how are we going to pay for it, the really, really simple answer is we're already paying for really poor healthcare with really high administrative costs. And when you take out a lot of the administrative costs, then you do have an overall lower spend for the system. Your question about what's provided is under clinical care, not administrative cost. So what we've been looking at so far is just about 20% of the whole picture. If you start to look at some of those questions about what care is provided, then you can get larger savings, because we're paying for folks that are actually not delivering good care. So there's really expensive impacts on human beings. It's an ethical issue as well as, a really high cost, because by not covering something when it's cheap, when it's early, then we end up paying really, really high prices later as a consequence of bad care. So if you start to look at both sides of it, administrative as well as medical cost, the proposal that you have better quality lowers cost dramatically. And that's within that context that I started this comment with, that we're already paying for poor care. So if we do it better, of course, it will be less expensive.
That is so helpful. And thank you for kind of like, bringing back that framing. It's true. Like this, this conversation currently is just about administrative savings. And yes, what the, the proposal will include other types of savings, healthcare cost containment and other types of savings as well. So I think that's a really good point as well, though. Thank you. All right. So I guess, sorry, because it's always hard when you see a laundry list and people ask you what's missing. But like I said, I tried to go through all the studies and just from, clinical experience, et cetera. And this is what seems to come up most. But of course, there's other things as well. So, and this is kind of it, I wanted to get to, and there's no right answers. We're not going to answer these, yes, but what is important when we're trying to think of the methodology for estimating administrative savings? Do we make sure that we have a range? Do we give an average? And these things I think are really important. One is, it's the end of March, but we've still got time. We want the proposal to be pretty well shaped up by the end of June, so it can go through some revisions, but we do still have time. So what needs more detailed study before the proposal is finalized, and what needs more detailed study in the next couple of years? Because that's really important too, and that's some of the stuff that we're working on. And again, it's a little sneaking in some transition work here into our operations. And then also, what does this mean? And I think, Anne, your point was really good. But when we talk about the plan to the public, because there are still going to be a lot of unknowns, and as much, ambiguity is very challenging. It's much easier when you have something very concrete and specific. And Anne, I'm definitely loving, and I think writing that down, hanging our hat on that, we are already paying for bad care. So let's pay for good care. I think that's one. But anyway, I'm just stop talking now and see if people have thoughts about this. Yes, Anne, please. And
Yeah,
then
just a really simple principle. When we were proposing lean projects, first of all, they were incremental. You do one at a time, you don't do them all at once. And secondly, we just adopted a standard assumption for a run rate savings. And it was usually around 15%. And for the estimates, we based it on the median current cost, because people always argue with you if you're conservative, or they argue with you if you're too ambitious. But if you just adopt, this is our current median for costs, then that dampens a lot of the opposition.
I love that. That is such a concrete example. Thank you. Mike.
Oh, first of all, yeah, thanks, Anne, for your comment as well. I was thinking about this, and I don't want to be totally humorous here, but that another way you were saying, Anne, that a comedian might say is, we're doing an outstanding job of paying more for poor care. And I think the question or comment that Anne raises, over the years, we've learned some things about quality improvement projects. And I think it's quite clear that while we'll clearly make some progress in the transition committee, the board will make some progress, that there's just a massive amount of waste, and that until we get to simplify things, to take Ann's piece here, it's like, well, we'll do one project at a time, but then the fundamental questions are regarding administrative costs, which ones are important. So I'm inferring, Ann, from your comment, that we might want to think of a game plan, really not just for our quote final report, but for the Universal Health Plan's approach of what's the game plan over the next year to propose some additional focused work on the areas of greatest savings. Because if we don't do that, and if we're too conservative and not bold enough, that's an issue. And on the other hand, we may run out of time in the next 3 months trying to measure all the aspects of administrative costs.
Yeah, and did you have?
Yeah, Mike, just generally speaking, the very first step is for the board to have establish criteria for how do you decide what the priorities are. Because if you start arguing about individual issues without having common aligned goals, factors that go into decision making, then that's a recipe for failure. So the first step then is just the criteria for how you decide.
That is great. Doug, I saw that you had your hand. Oh, yay. Yes, go ahead, please.
Yes, I would agree with Ann's earlier comment about I would choose the medium range as well. I think that would be absolutely the best place to start.
Thank you. All
I
right.
know this is probably not in the line of what we're talking about right now per se, but I'm trying to think, how do you measure provider reaction to all this? This is we're turning the world upside down in some cases here, and it's good, not bad, in my opinion. But I'm just trying to imagine, how do you measure, especially primary care providers, how do you measure their value in all this in the transition? I mean, it's very important.
Thank you. I think that's such a great thought. I know that people are very interested in really expanding the amount of engagement, not just with groups, but with all Oregonians, but obviously specifically impacted groups, and finding the best way to gather that type of information. So I know that that's definitely on the unfortunately there's not a lot of money in the budget to the end of this biennium, but it absolutely is something that we're looking forward to really being able to do it. And ideas like that, I think are
I appreciate the article, or the attached, I guess it was attached today, from Dr. Thompson in Corvallis.
Yeah.
It was well thought out, and I lived through a lot of that, and I recognize it. And there's even more than what he put in there, honestly. But it's he's right about so much for that. So
yeah. Okay. Well, like I said, I'm always here. So if you think of other things too, like if you're like, ooh, either I have a good study that I don't think you've talked about, or I, have really thoughts about something that I think is important to get nailed down in the next couple of months, you guys know where to find me. So next, I'm just going to go, this is going to be brief. But just a little rundown memory lane for all of the incredible work that this group has done. So you all started, you had your first meeting in 2024, and that was before my time. This one is the last one of this committee. And I just wanted to go over some of the incredible work and the proposals, and not just the proposals, but sometimes the evaluation and recommendation and that feedback loop with the board and coming back has been just incredible. So starting off with one of the biggest ones, which is of course, recommendations around a public corporation, and you had people from SAFE and Willamette Locks and OHSU, and there's a very robust proposal that the board was very happy with around a public corporation. Of course, federal waivers. We have great papers from HMA, both on the Social Security waivers and Medicaid waivers, and the possibility through the 1115 and the 1331 and 1332 waivers. Now, of course, that doesn't necessarily mean that it will be able to happen, but we have as much, a ton of good information. The Treasury Fund, also a great proposal. And then I think one of the biggest things that happened through this committee is the development of a really great administrative structure, and then looking at kind of the regional aspect and what it would look like. And between having, PEB and OEB speakers and Milliman, this committee has come up with a really excellent proposal with enough flexibility in it that I think it will be very beneficial moving forward. And then reviews and recommendations. I was going back through all the things, startup cost, regional operations, subrogation, primary care and behavioral health operations, eligibility and enrollment, the transition committee, IT strategy, and then federal health system interaction. All of these things this group has read on and commented on, and has really provided a tremendous amount of input that's going to go into the proposal. And then I thought, let's look at what we're going in the Wayback Machine to what the tasks were in the charter. So we're just going to go over these because we get to check them. Almost everything has been completed. To review public corporations, to understand administrative structures, done. I would say this next bullet is one that is probably way more ambitious than was realized when it was first done. So identify information technology needs, including cost benefit ratio of a statewide health information system. Well, that is that last bit has not happened yet, and that is still something that is going to be in the works and probably will happen over the next couple of years because it is a massive, complex undertaking. This group did this, reviewing complex healthcare administration and all of these systems, eligibility enrollment systems, startup and ongoing operational costs, and federal waivers. So these are all the tasks. The deliverables, which this committee did, administrative framework, all the statutory language to make an independent public corporation and also a trust fund. Those were the deliverables. Also, recommendations regarding IT needs, operational workforce needs. Again, estimate of startup costs. A lot of this is still contingent upon what is decided. So this is why I would say that probably the I don't even want to call it a gap, but the places that this committee was not able to get to mostly are around information technology, and then federal waiver guidance document and necessary steps for engaging CMS, all of which leads to me to this, which is like, this committee has done tremendous work and has been incredibly effective. So I know Judy Richardson, like I said, she was heartbroken not to be here. She's not supposed to have any favorite committees, but if she were, it's this one. I didn't hear that from me. So I'm going to leave it there. We have time for committee member reflections, and then we're going to wrap it up. So I've talked so much today. Apologies. Mike, it looks like you have something you'd like to add, please.
Yeah. Well, I echo what you said, Mimi. There, I would add that in addition to, I would build on Ann's comments by saying that for this particular concept here, a universal health plan at this particular time, doing it in a state, that I would add that simplicity maybe here is actually a design principle, that we've been inheriting so much complexity, and when you get into the weeds, you discover that there are so many even noble efforts, but had unintended consequences that given that, I congratulate you all as kind of just a recent member of the operations committee for all the work you've done, and I really hope that you stay in connection with all of us to make sure that we continue your work and build upon it, both as a board and as a transition committee. So I echo Mimi's thanks to all of you.
Thanks, Mike. Lori.
Well, the other thing that comes to my mind is there's so much that's in the process of being pulled out from under patients. I live in Southern Oregon, and Ashland Community Hospital is going to be reducing, their services in the next couple of months. And this was something that had no community input and very consequential. And so I think that the public is ripe to listen, with the thinking that, we're losing as we go along in our current system. And, really, there can't be anything worse than what we're experiencing in some ways. I mean, I know it could get worse, but, that there's a lot of concern for just the whole primary care as well as specialty care, and provider changes, reducing the number of providers who want to work in Oregon. I think there's a lot of reasons to offer an alternative, and I think that should be part of the conversation.
Thank you. Those are really helpful comments. Anne.
Hi, I just want to thank the support staff. I think you guys are doing a really good job. And this particular volunteer activity of mine has been very rewarding for me personally.
Thank you. That's great. I'm happy to hear that. Mike.
Yeah, one comment that based on what Lori was saying is, it is striking me that if we can imagine that we finally have a universal health plan, that it will have an important role in Oregon in when things like when institutions are going, out of existence, to kind of raise the flag and say, wait a minute, what is going on here? Hopefully the Universal Health Plan, by the fact that it will be essentially allocating funds by global health and other things to areas around the state, I would hope it would be dealing with healthcare disparities, including geographic disparities. And while it's not a big deal to go from Ashland to Merritt, that Ashland community, should that hospital close, is things, you will notice the change, because I have seen communities when a hospital closes and maybe something else eventually comes in, but these are important historical community institutions, and you know, hopefully, you know, this capability of this in our future board will be able to look at things seriously and proactively, and get Oregon to be a little bit more effective in figuring out, well, if they're closing, is there another way to compatible to at least keep some of the capability there, etc. It is disappointing to me to see when we just plain lose capabilities, especially in the rural parts of Oregon. So thank you, Lori, for that comment.
Doug, I noticed that you had your hand up. Did you have anything else to add?
I would just like to second Ann's comments. I think you guys have done a great job. It's tackled a very complex topic, and nice job.
Oh, thank you. All right. Well, I think since again we didn't have public comment for today, again, heartfelt thanks, gratitude for all the time this group has spent, gratitude for people who are willing to stay on to our transition committee. Very grateful, and absolutely would love to keep having people be involved. You will, you know, this group has so much insight into the way that things are working, and I really value it. So with that, you also get a little bit of time back, which is always fun. So have a wonderful rest of your afternoon. Take care, and we hope to see you all at some point later. Take care. Bye-bye.
Thank you.